Good morning to everybody. Thank you very much for the NCCM to inviting. Profo was in our center. He left us to Greater Pester, and he always refer case for the diagnosis. It's a great pleasure to work with him, and a very nice to see quite a number of audience in the Sunday morning. So we are staying in between prevention, between in treatment. So every patient should bypass hers before they embark into a specific treatments. Okay, so I like to not bore you. Okay, this is my content of slide. We talk a little bit of history, what's evolution of bronchoscopy, what's the advanced bronchoscopy that we do in our center. I will not talk about which is not available, which already done. All the cases is done by me, and also some interesting 5 cases to discuss. Okay, so I think the development of the lung cancer detection is way back in 17th century. Even though that time cancer is rare, thanks to the smoking, people start having a lung cancer. Then inventions of the chest X-ray and the sputum was used. So-called diagnosis, of course, the specificity and sensitivity is much lower. And thanks to the Godfrey and also Allen, who invented the CT scan, and the move forward towards the lung detection has become much easier. We're able to see all the anatomy in much detailed manner. In 2020s, 19th centuries, we're able to embark the patient to PET-CT to differentiate whether it's metastasis to distance other organ, and also we can target the biopsies according to the images. And of course, lately and now we are always doing a lot of EBAS, navigation bronchoscopy, and now we are not actually far away. AI going to be controlled soon. Okay, what's the evolution of bronchoscopy? In the theory, or you become the respiratory physicians or respiratory trainee, you need to know how to maneuver the bronchoscopy. It's been commonly used and is a basic tool every respiratory physician should master of it. Okay, and this is the type of the bronchoscopy we have. We have some for ultra slim to the therapeutic bronchoscope that is available in our center. I'll try to go a bit faster because my early speaker will keep the time perfectly well. I don't want to overshoot the time. And this is the case. You can see the CT scan, whereby if we have the large tumor sitting on the main bronchus, manual bronchoscopy enough to yield the diagnosis, and only thing you're worried about is the bleeding. Bleeding can be controlled with the many maneuvers. All right, so this is endobronchial lesions. We biopsy direct visualization, but using a normal bronchoscopy, we can diagnose faster. This patient we diagnosed adenocarcinoma, EGFR21. This patient is fit for the TKI. And these are a few cases you can see very clearly in endobronchial lesion. We can biopsies. All right. And what is the advancement done in the bronchoscopy images techniques by the many companies? Something called autofluorescent images, whereby you can differentiate which is a pre-malignant and malignant and normal endobronchial lesions by set up these autofluorescence images in your bronchoscopy. Second, we have something called confocal laser endomicroscopy. This is a bit more advanced, whereby you need a special machine which, when you light up the target lesion, you will give you in vivo images. From that in vivo images, the machine will categorize for you to biopsy this area. When you have the patient such as COPD patient, bronchitis patient, you expected all the layers of the bronchus going to be affected. We don't have this. And optical coherent tomography is much advanced, usually used only in the research purposes to get the better yield in the patients who have a suspicious lung cancer. Let's move it. This is the most commonly used, and we used it. There's a pro and cons using electromagnetic navigation bronchoscopy, because some of the electromagnetic bronchoscopy navigation does not support our CT image to be loaded into the system. So all of us go back to the manual mapping, actually is designed by the Japanese guys. So just give you a scenario of this. So when you see a lesion, so we load the images into the system will navigate for you when you're doing a bronchoscopy to achieve the target precisely and correctly, so that your yield towards getting the sampling is much higher. So that, because this is a peripheral lesion, so you need the image to guide you go to the lesion to get the biopsies. All right. Of course, now we are talking about robotic. Urology is already forefronting the robotic surgery in Malaysia. University Malaya already embarking on that. ENT actually complementing with the system doing the tonsillectomy, adenectomy using robotic. And what is the latest now? We're going to come soon in Malaysia is robotic advancement with 3D images. So it means the patient no need to do a prior CT scan. They do X-ray. If the lesion seen, We push them to the machine and they do 3D images. Then there itself you actually can decide what type target lesion that you can biopsy for the patients. So all this is evolving like a Ferrari car. If you see 1950s, 60s, 70s, now you have a latest technology, much faster, much furious, and all those things. All right. Okay, so what we do in our center, this is my single center experience, that what we do in order to diagnose patients. So as we seen earlier, if it's endobronchial tumor, main bronchial tumor, you can direct visualize patient to get the tumor. What happens if it's something not in the main endobronchial? So what we have is something called endobronchial ultrasound guided bronchial needle aspiration. This is what I do daily in my centers. This is another new invention. People say this is a cutting edge technology to aspirate the lymphatic mediastinal lymph nodes in order to get the diagnosis, which we will complement all the system with the cryobiopsy. Later I'll show the evidence why it need to be complement, because it give a higher yield to diagnostic of the tumors. So in Japanese group last time, they only dependent on the TBNA and also aspirate, so that they only can test it for EGFR. In my center, especially when Prof. take the studies from international trial, he need a big chunk of the tissues. They send for NGS, they send for many what they call investigation. So usually they need 0.8 to 1 centimeter size of tissue, so that this tissue can be analyzed. Usually they do a 33 panel, 50 panel, and all those things. Okay, so we will complement with cryobiopsy. I'll show you what's the cryobiopsy about. And this is actually how we set up cryobiopsy in our center. It comes with the herb prop, okay. So only one company is supplied in Malaysia. They have a different type of the cryoprop, 1.7, 2.4, and also 1.1, which is commonly used to aspirate from the mediastinal lymph nodes. Okay, so this is the another things we will complement those who have a peripheral lesion. It means the lesions are very near to the lung peripheral lesion. We use something called radial guided ultrasound. All right, so this is a much technical. Before we doing this, we need to have a lot of pre-preparations. We need to manual mapping, so that we need to identify which level of bronchi that we can go and biopsy. We need to prepare for any bleedings, and also usually in our center we do moderate constant sedations because we don't have a liberty to do under the general anesthetic. You can see this is ultrasound probe. Will scan the lesion. We can see in the images later on, which I'll show the live case later on. So once you identify the lesion, you put the sheets, and the ultrasound probe go within the lesions, whereby you can target the lesion. You can see concentric image on the right side. Then you use a forceps biopsy or use a cryobiopsy to got this lesion. Usually this lesion around 1.1 centimeter, 0.9 centimeter. You can see how tiny it is, so that we can get the sampling. Then the patient can go for early resection lung cancer treatment, because these are most of the cancer is not spread widely. Usually stage 1 and stage 2. Okay, so in nutshell, cryobiopsy is the most commonest that we do in our center. So what we do is, this is the preparation. You need to have a CO2, you need to have the pedal, prop, and also the cryo prop as well. What we use for, nowadays we're using for peripheral lung nodules. We also use for transmediastinal cryobiopsy. This is largest numbers that we did in past 2 years. And of course, we're using for those patients who are indeterminate interstitial lung diseases as well. Okay, and of course, I also use commonly for probiopsy. Nobody dare to use probiopsy because they're wary of the bleedings, right? So what are the things we need? Preparations. Any intervention, you need to have early preparations. We need to see the patient profile, patient's risk bleeding, patient tolerability to the sedations. Of course, we need to mapping, preparing to the instrument before to the patient come to the scope room. Sometimes we have a malfunctions of the needle, malfunctions of the instruments, and that's why we create a checklist in our scope room. We have a checklist before patient push to the scope room. We have a checklist when the patient arrives to the scope room, and of course we need to counsel the patient. So in Malaysia, we have something called, we call it dementia. When we already counsel the patient in the ward, the patient come to the scope room, we say, what procedure I'm going to? So that's why we have a checklist. You need to counsel again the patient and family. You see one son or daughter in the ward, you see next son in the water. The son said, oh, I don't know what procedure my dad going on. So that's how communicative we are within the family members. All right. So this is the case we published last year in MTS, talking about 140 cases the past 24 months that we shows high specificity and sensitivity by using cryobiopsies. Okay, let's go to the case discussion. This is the most interesting part I would like to share. Don't worry, I will not bore with all the statistics because interventions, pulmonology is more about hands-on work. And you have to see it, then only you embraced the technique and also you fall in love whenever you're doing the cases. So this is that's why as my boss used to tell, Dr. Jamalul said, a picture of words for thousands words, because you just imagination can, but when you do it, you can see very clearly. So this is case number 1, 70 males, your typical scenario we see in all the cases. I think Profo knows, came in with a constitutional symptom, SOB, chronic, no trauma. Patient came with respiratory distress, you do an x-ray, patient got massive proefficient. Clinically, you already know these patients have left-sided American pneumonia. Of course, we do a diagnostic tapping, looking for whether the patient is hemoserous, whether the patient lymphatic predominant. So this patient, we do procoscopy. Conventionally, people use forceps biopsy. If you got a pretty bad day, this is a very hardened pleura. None of your probe biopsy can work to get the biopsy for this. The only way you can get the biopsies for this kind of patients are using cryobiopsy. So I use a cryobiopsy 4 to 5 times, get a good chunk. You can see the sampling. I can finish the procedure within 40 minutes. Usually, proboscopy will take more than an hour because you need to go and bite and bite and bite. Okay, so this came back as a metastatic adenocarcinoma. All right. Okay, the next case is incidental finding of the left lower lobe nodule during the medical screening. This is early cancer cases we always refer to us. Please refer to cases to us. We will see all the cases we did 1-2 weeks in our time. Why I say 2 weeks? Because Malaysia got full of holiday. Sometimes Monday holiday, sometimes Friday holiday. So that's why I don't like to say 1 week, I say 1 to 2 weeks. All right? So this is the incidental finding case noted in the CT scan. You can see very nice chunk tissues, mass in the, nodule in the left lower lobe. So what we have done for this patient is actually, yeah, okay, I think the video is not playing. Yeah, there's a video not playing. All right, okay. Somebody can click the video at the bottom. That technician. Yeah. Okay. So you can see we have to prepare this patient. So we can see there's a mass on the left lower lobe. It's a nice bronchocyte. Normally you can't visualize directly on the bronchoscopy. All right. So what we have done is we have done this patient's all this method that we have to choose. Which methods will be better? So we chose this method. Maybe you can play the video. So this is me, and always we need a good assistance, all right? And we have the putting the cryoprobe, all right? So I have to visualize we use under the fluoroscopy as well. And we see under the ultrasound probe, this is called radial probe, where we need to see the ultrasound images. So then you have to look for this is a very nice concentric image. It means the ultrasound probe within the lesions, all right? So we managed to do a radial EBUS, did a cryobiopsy for this patient, and of course we will enhance our specificity, sensitivity to getting the target lesion by using fluoroscopy. All right. So yeah, so you can see this is a nice images. You need to look for it. If you got an eccentric image, we see I have the heart broken, so that is not a good image. Then you need to biopsy the patients. All right. So this is the good image, concentric biopsy. So what is the advantages? We using the combination radial EBUS, cryobiopsy, and fluoroscopy. Of course, is increased much higher hill. It's already shown in all meta-analysis and many centers as well. So this is difference. You can see using a forceps biopsy, you need to do a lot of punch biopsy, increase the bleeding rate. For the cryobiopsy, I use 1.1 mm probe. I just need to take 2-3, enough for me to go for NGS. Even all the oncologists or ourselves need for any testing is enough for the patient to go for all the tests. All right. So this patient adenocarcinoma, exon 19 is sent to the cardiothoracic for the resections. Okay. So you can see in all the studies is improved the diagnostic yield, reduce risk, slightly risk of cryobiopsy with the cryobiopsy, but not much we've seen. Patient bleeding slightly high on the cryoprobe, but it's not very high. We can control it. Of course, sedation is an issue. We use all our cases in the moderate constant sedations, and access for that is much easier. All right. So if you bleed, very easy. We put endobronchial. We wait until the bleeding stops. Then we come out. Then it's okay. So nobody died because this procedure. In the world data says only 4.9% of major bleed, and nobody died because of this procedure. Okay. This is a case tree. It's an interesting case. Ex-smoker came in with us. some history of polyposis in the colon, no chemo radiation was given. They say it's a benign lesion. Okay, he lost 5 kilo in 11 kilo in 5 months, no much of significant finding. Of course, they did a CT scan. Maybe can play the video at the bottom. So you can see in this scan there's a bilateral mediastinal lymph node, okay, and most commonly at this age, ex-smoker, with history of pre-malignancy, we're always worried whether this could be a malignant lung cancer or lymphoma and everything. All right, okay. So our diagnosis, mediastinal lymphadenopathy, whether it's a lung cancer or something else. So what are the technique we use for this kind of patient? Of course, we use this number C. So this you can see there's a metated lymph nodes. Within that there's the lesion. We biopsy this one. We send usually for 3 slides to combo our specificity to get the diagnosis. We send for the slide, we send for cytolite, we send for the clot coagulogram, and of course we send for HP with our cryobiopsy as well. So this patient, TBNA, everything came back, no malignancy. That's going to be devastating. All right. Always you think cancer, 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 cancer. Suddenly we will see everything back again. So what will be the next? Whether we wait for repeat CT scan in some time later, watch and wait. None of the patient will be very happy to you if you're waiting for next. Okay, wait for 3 months. Okay, or it will become a cancer or lymphoma. So what we usually do, if we suspected some malignant, not malignant, maybe not malignant, we will send all this patient for TB gene expert, direct SME and cultures, all right? So the histopathology result came back as sarcoidosis. So sometimes you have a mimicker, can trick you, maybe not a cancer, it can be sarcoid. So this is the stage 1 sarcoid, normally no need to treatments, all right? So you have to send many sampling in order to iron out all the differential diagnosis, because Malaysia is very common for the TB. So not only we send for HP alone. So this is a case, a good illustrative. So as I mentioned, this is a confirmed sarcoidosis of the mediastinal lymph nodes. Case 4, maybe you can play the video for me. 65 years old, ex-smoker, diabetic, obstructive sleep apnea. Then also patient came with a constitutional symptom. So clinical finding, nothing much. So there you can see the CT scan, large mediastinal lymph node. You can see the peripheral pre-highlight lesions enlarged. So we subject this patient to one of our techniques. So we did the EBAS, needle aspiration, and it came back as suspicious atypical cell. All right. So this patient, you play the video, please. All right. You can play the video. If you cannot, it's okay. Yeah. So this is how I put the prop. We need to put a tunneling. So we use a few method tunneling. I use a larger EBAS to make a tunneling, go into the lymph nodes. All right. Then we will take the aspiration. After the aspiration, we use the cryobiopsy to take the samplings as well. All right. So these are a few biopsy samples enough. We can finish the procedure faster compared to last time. You need to puncture a few times to get a good yield of the TBNA. So it came back at Hodgkin lymphoma. All right. Okay, this is the why important of EBAS. EBAS TBNA not alone able to diagnose lymphoma, because lymphoma need more thing. You can see only the sensitivity is low, specificity is high. So the meta-analysis shows patients who have a suspect lymphoma must go transmediastinal cryobiopsy, because the sensitivity and diagnosis is much higher with the cryobiopsy. This is a very interesting case. All right. So this is 63 years old ex-smoker, presented to us. A pain over the left hip, month, radioculative pain, exorbit on excision, loss of weight, loss of appetite. Common scenario, we receive the patient. He has some sensory issues, but everything is normal. You can see X-ray, something abnormal on the anterior mediastinums. All right. So this is a PET CT via subject patient. Maybe can play the video for me. Okay. So this is one of my neurosurgeon consultant relative. So of course she got a super fast access. You can see large lesions over here. So I think we straightforward case. We send the patient for TBNA, EBAS, and cryobiopsies. All right. Not every day is Sunday or Monday. So we use the TBNA cryobiopsy. C is our favorite method. So can play the video. So when we actually embark the patients on the mediastinum, you can see large vessels sitting within the lymph nodes. So we can't do anything with this kind of lesion. I can't do a cryobiopsy because the patient will bleed and death. Okay. So you can see I already made the Dopplers, a large vessel in the center of the mediastinum. So only thing I can do is the TBNA. We managed to do a TBNA for this patient, can't do cryobiopsy. I got a very good sample for cytolites. We can see thread-like appearance, and this is enough to get a diagnosis for this patient. Japanese group only depend on the cytolite to diagnose the lung cancer in the centers. A very difficult procedure, a very challenging procedure. yes, your pathology will always upset you. Alright, they say suspicious malignancy. There you need to scratch the head. Okay, so I learned a technique from Dr. Gary when I was go for the advanced growth management. Okay, he always tell, speak to your pathologists, because the pathologists, when they slice, they only cut in between. You know, they don't cut all bottom of the thing. So I speak to my pathologist. Prof Ho knows how difficult to speak to a pathologist. Okay, he's smiling and you guys know the answers. So I speak with them. Why not we cut much deeper and look into the detail? Yes, at last they give the diagnosis. It's a squamous cell carcinoma. All right. So it's always not a straightforward, easy day when you do a procedure. So many teams are involved. Your pathologist always is the decision maker. They say no enough cell, you have to go biopsy, but always you can convince them, talk to them, or you send for second opinions. All right. So what's the picture? We are doing a lot of liquid biopsy. Genomic is coming on the way. Of course, artificial intelligence is on the way, and also breathnomic. All right. This is our team. Thank you very much. Thank you. Thank you.